Well, hello, everyone. Welcome to today's webinar, Keeping Kids Healthy This School Year. The CDC Foundation is so pleased to host this webinar in partnership with the Vaccine Equity Cooperative and Health Leads. This webinar is part of our ongoing work and commitment to support those of you working in communities and partnering with communities to fight this pandemic. I'm Dr. Lisa Waddell, the Chief Medical Officer for the CDC Foundation, and pleased to serve as today's webinar moderator. Now, today's webinar is available in Spanish. To listen to this presentation in Spanish, click the globe icon at the bottom of your Zoom screen and select language. This webinar also has closed captioning as an option. To enable closed captioning, please click the closed captioning icon on the bottom of the Zoom screen. Now, before we begin our conversation today, there are a few housekeeping items we'd like to review. First, today's webinar will be recorded and sent to everyone who registered along with any materials shared. Second, during the webinar, we'll have time to answer as many questions as possible, so please submit your questions using the Zoom Q&A button at the bottom of your screen. And then third, you can use the Zoom chat feature to share comments, reactions, and links with your fellow attendees and panelists. And then last but not least, we will launch an evaluation survey at the end of the webinar. So we appreciate you taking just a moment to share your feedback on today's webinar and suggestions for future offerings. Now, during our conversation today, our goal is to share as much information and guidance as we can on how to keep our kids healthy during this school year. Next slide. Our speakers will share the latest updates on COVID-19 vaccine guidance for school-aged children, as well as the latest data and insights into what's currently happening in both communities and schools right now, including suggestions on how we can overcome common barriers. Our speakers will also highlight a new set of recommendations at the federal and local level that federal and local officials can use and you can use to promote equity in both COVID-19 and routine vaccinations. These recommendations, which you will see that we are sharing in the chat, were created by the Vaccine Equity Cooperative Kids Vaccine Working Group, whose authors, some of them are included in today's webinar as speakers. Now, to make sure your communities have all the information that they need on this topic, we are thrilled to have a number of expert speakers with us today. Links to their bios can be found in the chat. We have Mr. Robert Boyd with the School Health Alliance, Dr. Mark Del Monte with the American Academy of Pediatrics, Dr. Lauren Smith with the CDC Foundation, Dr. Cameron Webb with the White House, and Dr. Sarah Meyer with the Centers for Disease Control and Prevention. Now, this is an important topic, and we've got a lot to cover today. We're first going to hear from Dr. Sarah Meyer, who is the Chief Medical Officer of the CDC's Immunization Services Division. Dr. Meyer is going to start us off with an overview and reminder of what COVID-19 vaccines and boosters are approved and available for the 5 to 17-year-olds, as well as any specific guidance we need to keep in mind. So with that, Dr. Meyer, the floor is yours.
Thank you so much, and good afternoon, everyone. It's a real pleasure to be here with you today. So yes, I will be reviewing kind of our current guidance for COVID-19 vaccination for children, including school-aged children. Next slide. All right, I can skip this slide. All right, so first I'll start with some breaking news from today. So you may be aware that today FDA authorized both Moderna and Pfizer-BioNTech bivalent COVID-19 vaccines for our younger pediatric age group. So now children ages 5 years and older are also eligible now to receive an updated bivalent COVID-19 vaccine booster. Previously, before this, about 6 weeks or so, our adolescents 12 and older had been authorized to receive this bivalent booster, and now this has been extended down to children 5 years and older. Next slide. So just to kind of recap where we're at now with our bivalent booster recommendations, including with today's newly added younger children into this, everyone ages 5 years and older is recommended to receive one age-appropriate bivalent mRNA booster dose after completion of any FDA-approved or FDA-authorized monovalent primary series or the last monovalent booster dose. So before I get into this a little bit further, I just want to make sure to kind of explain what we mean by a monovalent or a bivalent booster. So bivalent is the new updated booster dose that contains the original formulation of the vaccine, as well as a component that will help protect against some of our newer variants, the BA4 and BA5 Omicron variants. So the bivalent means that we have the components of the original vaccine as well as those targeted specifically towards Omicron, which is currently circulating. What I mean by monovalent is basically the original booster dose. So now, anybody ages 5 years and older is recommended to receive this updated bivalent booster. But people need to have at least completed a primary series. So they at least needed their first and second dose of the vaccine. And, or if they've gotten any number of booster doses in the past, they are also eligible to get this updated booster dose. People can get the same vaccine as they've had before, or they can mix and match vaccines. So that's what we mean by any homologous or heterologous boosters. So if somebody got Pfizer for their primary series, they can either get Pfizer or Moderna for their booster dose. Likewise, if somebody got Moderna for their primary series, they can get Pfizer or Moderna for their booster dose. So right now, there are no changes to the vaccine schedule for children less than 5 years of age. For children less than 5 years in age, they are still recommended to get a primary series, but they are not yet eligible for a booster dose. Next slide. So I know people are aware of some of our prior recommendations around booster vaccination. People have heard that we've had one booster or a second booster. People are, recommended to get multiple boosters. Now we're talking about our fall booster. This gives us a chance to kind of reset and simplify our recommendations. So instead of counting how many boosters somebody's gotten, what we really want to emphasize is that everybody should get an updated booster this fall. So it doesn't matter if somebody's only had their primary series, if they've had their primary series plus one booster or two boosters, everybody should now get one bivalent or updated booster dose as long as it's been at least 2 months since their last dose. Next slide. So now I'll walk through the schedule in a little bit more detail. So first we'll start with our children 5 to 11 years of age. And this is the group that just, the authorization just got amended today to allow them to have an updated booster as well. So if we start with our, I'll start with our 5-year-olds specifically, because as people might be aware, there are some differences in what's authorized in our younger groups. So for 5-year-olds, only Pfizer is authorized for the updated booster. So they have to get Pfizer for their updated booster. So they get their first primary dose, and then either 3 or 4 to 8 weeks later, they get their second primary dose. And then at least 2 months after that, regardless of if they've gotten any previous booster doses, they are recommended to get a Pfizer bivalent booster. For children ages 6 to 11 years of age, similar primary series recommendations, but they can get either Pfizer or Moderna for their bivalent booster. Next slide. For children 12 to 17 years of age, for their primary series, they can either have had Moderna, Novavax, or Pfizer. So after their 2 doses of their primary series, as long as it's been at least 2 months since that dose, they are recommended to get either Pfizer or Moderna for their updated bivalent booster dose. Next slide. And then I know we're focused on kids today, but I did just want to summarize our adult recommendations, which will be important for keeping everyone in our schools, our adults in our schools, our teachers, our educators, other staff, and for us as their parents and other loved ones, so that everybody in the family is up to date on their vaccines. So for people ages 18 years and older who got either a Moderna, Novavax, or Pfizer primary series, after their 2 initial primary doses, they are recommended to get either a Pfizer or Moderna bivalent booster at least 2 months later. And then for people 18 and older who got Janssen or the J&J vaccine, after they've had their primary dose, they are recommended again to get either a Pfizer or Moderna bivalent booster. And this, again, as I mentioned for children, this is irrespective if they've only completed their primary vaccination or if they've gotten any number of booster doses prior to this. Next slide. So I mentioned this a little bit earlier, but just to kind of reinforce this message, it can be for the updated bivalent booster, it can be the same as people have received for previous doses or different. So homologous meaning the same, or heterologous meaning mix or match, this is allowed. So if people got Moderna primary series, they can get Moderna for their booster, or if people got Pfizer for their primary series, they can get Moderna as their booster. And that would be an example of mixing and matching. The reverse of what I just mentioned also holds true. So people can get the same or they can get different from what they've previously received. Next slide. And then in terms of when a timing of an updated booster, since if people recently had a SARS-CoV-2 infection, I just wanted to review that because I know a lot of people did get sick with COVID over the summer, and we get a lot of questions about that. So what we recommend is that at a minimum, people should wait to get any of their COVID-19 vaccine booster doses, including their updated bivalent booster dose, until at least they've recovered from their acute illness if they had symptoms, and if they are no longer isolating at home, so that they don't expose other people when they get their vaccine. In addition, we also say that people who recently had SARS-CoV-2 infection may consider delaying their COVID-19 vaccinations by 3 months from the time when they had symptom onset or their positive test. So, essentially people have the choice. You can wait 3 months to get your updated booster if you've recently had an infection. Next slide. And then we do also recommend that people can get their influenza and COVID-19 vaccines at the same time at the same visit, which is what we mean by co-administration. So we recommend that providers should offer both at the same visit if eligible. This includes some of our influenza vaccines that we typically give to older adults, like our adjuvanted and high dose influenza vaccines. We just recommend administering those in separate limbs. Getting both of these vaccines is really important for the prevention of severe disease, hospitalization, and death for both. And getting them both at the same time increases the chances that someone will stay up to date on their vaccination. So it's definitely something we recommend. And we do have now quite a bit of data to show that this is safe and it doesn't affect the immune responses to either of the vaccines. Next slide. And I mentioned the importance of staying up to date on vaccinations. By that, for COVID-19, we say that you are up to date if you have completed a primary series and received the most recent booster dose recommended to you for you by CDC. So essentially what this means is we recommend that everybody get their primary series and get their updated bivalent booster vaccine to stay up to date on their COVID-19 vaccinations. Next slide. All right, thank you very much.
Thank you so much, Dr. Meyer, for that very timely, hot off the press information and all those really important updates, and for presenting that in such a clear and concise manner. And just as a reminder, everyone, we will be sharing these slides with you afterwards, so you will have these very nice slides with this very clear messaging afterwards. So now it's really my pleasure to introduce Dr. Lauren Smith. Dr. Smith is Chief Health Equity and Strategy Officer at the CDC Foundation, and she will present an overview of the latest COVID-19 data trends for school-age children and speak to some of the best practices and recommendations to equitably increase vaccinations. Dr. Smith.
Thank you, Dr. Waddell. Next slide. Next slide. So I wanted to start off, and maybe back one. Many of you who go to the CDC website may see this. I wanted to start with just because we're so interested in the equity aspects of how is COVID-19 continuing to affect our children. I wanted to share this information with you so that you were aware that this way of depicting the data is available. This shows weekly cases per 100,000 children by age group and by race. So you can see that it's separated for American Indian, Alaska Native, Asian Pacific Islanders, Black, Hispanic, and white. And basically you'll see in all of those groups are the age group that we're talking about, which is shown in gold here, the 0 to 4, 5 to 11, and 12 to 15, and then 16 to 17 is going down. We did have 40,000 new cases in pediatrics last week, which was last month, which is down from 90,000 the month before. Next slide. These graphs showed new admissions of patients with confirmed COVID-19. And again, this is as of October 9th, so very recently. And I really just wanted to point out that the information in gold on the right, which is the 0 to 17 age group, you can see that it's the bottom, right? So there's, in terms of overall numbers of admissions, pediatric admissions, the numbers aren't that high, which is a good thing, but because it's relatively low compared to all of the adult admissions, and especially for the older age group, it means that people may often underestimate the importance or impact of pediatric hospitalizations. And I think it's because they can almost ignore the gold line at the bottom, even though we know that has, significant impact on those children who are affected. Next slide. This is just another way of showing this is, again, CDC data. If you look at percentage of hospitalizations in the younger age group, 0 to 4, and then 5 to 17, you can see it's this very small percentage at the top, but yet it's really meaningful for our families and our communities. Next slide. So in a study of 400 kids that were aged 5 to 11 years that were hospitalized during the Omicron wave, earlier this year, it's important for you all to know, and for us as pediatric caretakers to be able to communicate that 3 in 10 of those children had no underlying conditions, because that's important to emphasize, because there's potentially a false narrative that only kids with underlying conditions are the ones that end up hospitalized. So 3 in 10 did not have an underlying condition. 9 in 10 were unvaccinated. That is an important message to consider. And 2 in 10 needed ICU care. So they were 20% of those admitted needed really substantial support. However, and again, I think that this is really important, even among those children who had to be hospitalized, none of the vaccinated children required a higher level of oxygen support. So they didn't need to be on a ventilator. They didn't need additional accessory machines to be able to help them breathe. That's really important. So even though they had to be in the hospital, they didn't require that extra level of support. not surprisingly, or we could have said predictably, there were documented inequities, including that Black children made up the largest proportion, 34% of the unvaccinated children. And we're going to come back to that and what the implications of that are. And Black and Latino children were much more likely to have severe disease compared to their white peers. So really wanted to sort of stress the idea that although the total or absolute numbers of children who are hospitalized are relatively small compared to older adults, the important thing here is that so many of them don't have underlying conditions, that the rate of vaccination is low among those who are hospitalized, and that those who are hospitalized, a significant portion of them have needed ICU care. Next slide. So then, if that speaks to the importance of vaccination in offering such important protection for our youngest among us. And what I wanted to share here is, again, this is information from the CDC. And if you look at the gold, which represents the dashes and dots are all for children under 17, you can see that over time, the highest proportion of children receiving at least one dose is the 12 to 17 age group, which is 71% have received one dose. And that's compared to the older age groups, where among those over 65, as an example, at least 95% of that group has received at least one dose. If we look at who's completed their primary series, then the percentages are even lower. But what does this mean sort of in terms of going forward? Next slide. This graph, or rather this map, let me sort of help orient this, this map that the CDC, again, produces. The colors in the squares to the right of the graph are mapped to percentages of the 5 to 17-year-old age group who've completed their primary series. So we learned what that was in terms of receiving their 2 doses of vaccine. Across the bottom is a social vulnerability index, which is a marker that the CDC uses that's a compilation of many different factors in terms of percentage of folks who are living under the poverty level, levels of education. There's a whole number of items that go into that. But the thing to see here really is that the cluster of communities with high levels of social vulnerability and low levels of immunization of children, that red color that's in the lower right corner of that matrix, you see a lot of that across the whole sort of South and in areas of the West. Next slide. So what's the specific COVID vaccination status as of October 5th? And again, thank you to the AAP for providing these analyses of the information and data that's available at CDC. For the 6 months to 4 years, there's 1.5 million children. So that's the group that's had the most recent authorization to allow them to be immunized. So that's 9% have received at least one dose. But that leaves 15.6 million kids who haven't received any doses. And the rate at which that age group is getting vaccinated was about 40,000 in the prior week. If we go to the next age group, 5 to 11, that's looking a little bit better. 10.8 million children, or 38%, have received one dose. 8.8 million, or about 31%, have completed their 2-dose series. But again, that leaves 17.8 million who haven't received a first dose. And that group is not getting vaccinated at the same rate, about half the rate, in that they had 20,000 doses the prior week. And then finally, with the 12 to 17-year-old group, 17.6 million, or 67%, 2/3 essentially, have received one dose. That reflects the fact that they have had they've been eligible for vaccine longer. 15.1% or 58%, so a good chunk has received 2 doses, but there's still 8.5 million children in that age group who've not received a single dose. And again, their rate of getting vaccinations in the prior week was 20,000. So in sum, that means there's 42 million kids under 18, or 58% of all kids under 18 who haven't received a single dose yet. Next slide. So just so you could try to do some of that math, I thought it would be important to share, if we kept the same rates of vaccination, that the 40,000 in the 6 month to 4 year group, and then about 20,000 in the other 2 age groups, it would take us 390 weeks to reach the 15.6 million kids who haven't gotten a first dose in that youngest age group. It would take 890 weeks, which is 17 years. Obviously, that's impossible to reach the next age group. And then, as you can see, 425 years. And so all that is just to say that it's the current pace of vaccination is not going to meet the needs that we have and the desire to protect our children. The graph on the right, I know it's a little bit hard to read, but essentially you can see that early on, the 5 to 11 age group was getting 1.6 million. That number that maybe is a little bit hard to read is 1.6 million doses per week. And you can see it's trickled down sort of substantially to 21,000. So part of what I wanted to emphasize is that not only do we have to increase what we're doing, but we need to be specific around really upping the rate at which we're trying to connect with these kids. And then last slide. So some key themes in thinking about equitable vaccination in kids, certainly promoting vaccinations in their medical home. Most kids receive their routine immunizations in their medical home. So assuring that those places are prepared and equipped to be able to do that. However, school-based efforts are a crucial bridge for children who don't necessarily have a medical home or are have a sort of unstable or incomplete access to their medical home, and supporting local and state public health departments to foster those connections between schools and medical home and to coordinate outreach and education will be really important. Maximizing the use of Vaccines for Children program that's been effective for routine immunization. So it makes sense to look at that for this. And the last two really are around using trusted community members and leaders and having a no wrong door approach so that we open all avenues to ensure that these kids can become immunaids. And at the bottom are a couple of resources from CDC and the Vaccine Equity Cooperative that you'll get when you get the slides.
Wow. Thank you so much, Dr. Smith. That was really some compelling data, as we saw one of the comments in the chat, compelling data in terms of the issues that really do happen when we have our children hospitalized, the documented inequities. And I hope everyone leaves this webinar with that map in mind, that we still have so much more to do. No child should be without this protective vaccination. So let's move on to Mr. Robert Boyd. We want to thank you for joining in this conversation. Mr. Boyd is the president and CEO of the School-Based Health Alliance, and he's going to discuss what's happening in schools now and highlight a few local bright spots for all of you. So, Mr. Boyd, to you.
Thanks, Dr. Waddell. Please keep Dr. Smith's data and comments in mind as we go through my presentation. First, I bring you greetings from all of the school-based healthcare providers who serve our students every day. Now, school-based health services are greatly misunderstood, so let me set a common understanding for us. Next slide, please. Everyone agrees that healthy kids learn better. School-based health services are the fusion where education and healthcare meet. Those who provide health services in schools include school nurses, psychologists, school counselors, social workers, health educators, and nutritionists. They are generally employed by the school district or are under contract to provide services to the district. There are literally hundreds of thousands of school health professionals serving the millions of K-12 students. Unfortunately, there aren't enough of them to meet the needs, and they aren't well distributed. In other words, many schools in rural, low-income, and communities of color have few health professionals serving them. Then there's also the staff that works in the school-based health centers. Next slide, please. So what's a school-based health center? It's a shared commitment between a school, a community, and local healthcare organizations to support students' health, well-being, and academic success by providing preventative, early intervention, and treatment services where the students are in their schools. School-based health centers work under an agreement with the school to provide healthcare at the school in partnership with the district staff and at no cost to the school. We are not competitors. We all work together to serve the students. A school-based health center would likely have a nurse practitioner or physician's assistant, as well as behavioral health professionals, but could also have access to oral and vision care professionals. Next slide, please. So what kind of services can you expect to find in schools for kids, health services? And traditionally, the school health examples might include school nursing services, speech therapy, counseling, nutrition-related services, occupational therapy, and chronic care management for diseases like diabetes and asthma. Now, if you have a school-based health center, you would also get a full range of medical, behavioral, and preventative health care. Next slide, please. This afternoon, we're focused on vaccinations in schools. I think from Dr. Smith's data, you see why. The Community Preventative Task Force of the CDC, which are not employees of the CDC, but community leaders in their field that come together to make recommendations. That particular task force recommends school-based health centers and school health services in school because the data shows strong evidence of effectiveness in increasing vaccination rates and decreasing rates of vaccine-preventable disease. They also recognize that schools provide health services also have better academic outcomes. Healthy kids learn better. Next slide, please. So what happened during the pandemic? We got creative. School-based health professionals delivered vaccines wherever they could, even curbside in parking lots. Next slide, please. We hosted immunization events. We coupled them with routine vaccinations and wellness visits, and we paired them with food distribution. And every day, school-based health professionals work to build the community's trust, especially among parents. They work despite the misinformation about the safety of vaccines that's being spread in social media and other media. Next slide, please. Misinformation is one of the most significant issues facing school-based health today. Lauren has already spoken about some of the data that's out there. Maybe Mark's going to talk some more about vaccination rates, but they are down significantly, particularly routine vaccinations. We need to be on the lookout for cluster outbreaks of preventable diseases. Vaccines prevent diseases. Another critical issue to us is workforce depletion. There weren't enough health professionals willing to work for lower wages in schools before the pandemic. In the last 2 years, many have retired or have taken better paying jobs elsewhere in the healthcare system. School-based health professionals are overworked and underpaid. We all know this. We also ask them to do way too much. For example, we all agree that there's a mental health crisis in K-12 schools. Yet the school psychologists report that their membership is responsible for over 1,160 students per professional, despite a recommendation that they serve no more than 500 students. The school counselors and social workers also report serving more than twice the recommended number of students. When you recognize that there were only about 3,000 school-based health centers before the pandemic, the options for receiving preventative health care in a school were not good. This is particularly true in rural, low income, and communities of color. We have some schools that want to open school-based health centers, but their local healthcare partners cannot staff them right now. And while Congress has appropriated new funds for districts to hire things like more behavioral health professionals and to open more school-based health centers, as one colleague serving rural Arkansas said to me recently, that's great, but where are we going to find the professionals? We don't even have them for our general population. We must create a pipeline starting in middle school to attract students to careers in school-based health services. And that pipeline must emphasize the recruiting of professionals that reflect the communities they serve. This is critical to building that trust we've talked about, particularly with parents in rural, low-income, and communities of color. Now, I want to end by sounding an alarm. Some of you will think that I've already been sounding it, but here's the alarm. These are not good times for school-based health professionals. Our kids are at the mercy of those who deny the efficacy of vaccines and of science in general. Vote. You must vote as if your lives, those of your families, and those of the students we serve depend on it. We are hopeful, though, and we are committed to providing healthcare in schools, particularly for those with the greatest need. Why? Because we understand the simple promise that healthy kids learn better. Thanks to all of you who are healthcare professionals out there serving our kids. We appreciate you. Thanks for all that you do. Back to you, Dr. Waddell.
Thank you so much, Mr. Boyd. And again, thank you to all of our school-based health professionals. We know they are stretched, and we appreciate you so much, particularly those of us who, when our children were in school, really appreciated what those school nurses did and still do. And we heard from Mr. Boyd the importance of creating a pipeline in middle school. So let's certainly keep that in mind. So I'm really pleased to now turn the podium over to Dr. Mark Del Monte, who is the Chief Executive Officer and Executive Vice President for the American Academy of Pediatrics. Those are our children's doctors, you all across this country. So we are so pleased and privileged to have you with us today. The podium is now yours.
Dr. Waddell, thank you very much. It is an honor, certainly, to be with all of you here today, and thank you for taking time to talk about this important subject. I'm honored to be able to give a few perspectives from the American Academy of Pediatrics on how to center equity as we consider how to keep children safe and healthy in their schools. One of the most critical lessons of the COVID-19 pandemic is the importance of in-person school. Remote learning exacerbated existing educational inequities, was detrimental in many ways to educational attainment, and worsened the growing mental health crisis among children and adolescents. The AAP has called for safe in-person learning since its original school guidance in June of 2020. Schools do not significantly increase community transmission, especially if reasonable guidelines from WHO and CDC and UNICEF is followed. And so schools and school-supported programs are fundamental to child and adolescent development and well-being. They provide our children and adolescents with academic instruction, social and emotional skills, safety, reliable nutrition, mental and other health services, and opportunities for physical activity. So as we think about schools, school policies should protect all students, all school staff, all teachers, using science as their key guide. So we should ensure that school administration and medical staff, like school nurses and nurses' aides, are given the training and funding they need to be regularly updated on changes and able to implement the latest in recommendations regarding COVID. So first and most important, the AAP recommends COVID-19 vaccination for all eligible children and adolescents using a COVID-19 vaccine authorized for use in their age. And as we just heard, it's a good day for kids because the Pfizer bivalent booster and the Moderna bivalent booster have both been authorized for school-age children just today. In addition to students, teachers and staff should also be vaccinated against COVID-19 as CDC guidelines indicate. This is the single best strategy to protect students and staff from severe disease, hospitalization, and death, and to maintain in-person learning. In addition to COVID vaccine, other routine immunizations should be discussed with students and parents. We should work together with schools and local public health to promote childhood vaccination messaging all throughout the school year. It is vital that all children receive recommended vaccinations on time and get caught up if they are behind as a result of the pandemic or any other reason. And in addition, although flu vaccine is not generally required for school attendance, it should be really encouraged for all students and staff. The symptoms of flu and COVID-19 are similar, and so taking steps to prevent flu will decrease the incidence of disease in schools and the related lost educational time and all the excess resources needed. Secondly, school policies should follow mitigation measure strategies to prevent the spread of the virus. Although not required now in many school districts, indoor masking is still very beneficial. Families should especially consider masking for their child with well-fitting masks if their child is ineligible for a COVID-19 vaccine for medical reasons or because they're immunocompromised, or perhaps they don't have an immune response to the vaccine, or they're at high risk of severe disease or illness because of COVID, or if members of their family are at higher risk for severe disease, or if they themselves are not immunized, or if you're living in a community with a high COVID-19 transmission rate. Another mitigation measure is ventilation. It's time to improve ventilation in school buildings. Ventilation helps reduce exposure to COVID and other respiratory pathogens, and it helps dilute the amount of virus in the air. Improving indoor air quality is an overall good for children and school personnel as well. And in addition, increasing the flow of clean outdoor air when conditions permit, these other simple measures are available, like properly placed fans, the use of portable HEPA units that are the right size, or creation of directional airflow in rooms can help improve indoor air quality. And of course, we can't forget the basic strategies like hand washing and appropriate school cleaning. And lastly, I'd like to say a word about the digital divide. The digital divide has been a known disparity for decades, contributing to the homework gap, which is the gap between school-age children who have access to high-speed internet and adequate devices at home and those who don't. Some studies suggest that 35% of lower-income households with school-age children did not have broadband internet connections at home. And 1 in 5 teenagers are not able to complete schoolwork at home because of a lack of a computer or internet connection. This technological homework gap disproportionately affects families living in poverty, particularly families of racial and ethnic minoritized communities. With the transition now to more virtual learning during the pandemic and the ongoing increasing use of online learning outside of school, this just gets worse. In April 2020, 59% of parents with lower incomes who had children in schools that were remote because of the pandemic said their children would likely face at least one digital obstacle to their schooling, like a lack of reliable internet, no computer, or the need to use a smartphone to do schoolwork. Gains have been made over the past 2 years with creative local and state solutions working towards providing improved access to technological devices and internet connections, but this gap still exists, particularly for students living in poverty or in transitioning housing or in temporary housing. So this is a critical component to be addressed in schools, even as children return to in-person learning and they're navigating this new environment that they're in. Long-term sustainable funding is needed to support school districts in providing universal internet access and technology for all students. And we should keep working on this no matter the state of the pandemic. Thanks for the few minutes to join you today, and I look forward to the questions.
Great. Thank you so much, Dr. Del Monte. Such important information and such an important reminder around the digital challenges that very much impact our children, our young people all across this country in many, many communities. So while progress has been made, much more to do. And so with that backdrop, I turn to our colleague from the White House, Dr. Cameron Webb, who is the Senior Policy Advisor for Equity COVID-19 Response Team. And Dr. Webb will inform us on the federal government's latest initiatives and their push to increase kids' vaccines and boosters. Dr. Webb.
Well, thank you so much, Dr. Waddell. It's great to be with you all. this afternoon. And I know we're running a little bit over time for the presentation. We want to make sure we save some space for the Q&A. But the great news is that my colleagues and folks who preceded me have covered a lot of the really important content already. So I just want to hit a couple of highlights on where the federal government's efforts really connect with what's happening at the state, local, and community level to make sure that we're able to keep kids safe and healthy this school year. The first is on the availability of vaccines. That's both kind of the primary series vaccines and the boosters as well. And you heard the update already from our colleagues at the CDC about the availability of these new updated vaccines or the bivalent boosters that are available for kids. So that's kind of late breaking news, just happened today. The Pfizer doses are going to start shipping out over the next couple of days, or will be available really into the weekend. But I think the important thing there is that it reinvigorates the conversation. These vaccines are going to be available in tens of thousands of locations in communities. So that's certainly going to be at primary care providers' offices, at pharmacies, and in other community settings. And I think that's a really important dynamic for us to look back into and lean into. Of course, you've heard the importance of kind of that co-administration conversation. So the same time that we're focusing on getting our kids vaccinated for COVID-19, getting them vaccinated for the flu as well. And as Dr. Smith pointed out earlier, we do see some inequities in vaccination rates. And so yes, while we've got these new boosters available, we shouldn't turn away from the fact that there's still a lot of folks to vaccinate. And I'll talk about the public education campaign in a second, but just want to start by putting or double clicking on, looking a little bit closer at what's happening with those inequities. We certainly saw some of the data from COVID data tracker that Dr. Smith showed by race and ethnicity. But even if you frame this by rural geography versus urban geography, significantly less likely to be vaccinated for kids 5 to 11 in rural communities. It's around 15, 16% versus 40, 43% for kids in urban communities. So again, huge differences there. There are ideological domains there. There certainly are some geographic and other social dynamics at play, but it's so important for us to recognize that you can't look at the United States as one whole. You really have to look at each individual community. You have that overlay of rural geography. You have that overlay of race ethnicity where we see those different dynamics. So when we talk about availability, we really have to start by talking about getting these vaccines into as many community locations as possible. That's what we've aimed to do. We framed vaccine access or kind of overcoming vaccine hesitancy throughout this pandemic through those 3 C's of convenience, which is kind of the availability piece, and then confidence and complacency. And I would say those last 2 C's really are critical to us in the vaccination effort in the weeks and months to come. In terms of confidence, we're continuing to move with our public education campaign. We didn't get additional funding from Congress. It made it really hard for us to continue to have that really world-class public education effort, getting information out to parents and families about vaccines for kids. But we've been able to shuffle around some dollars at Health and Human Services to try to have somewhat of a effort for the booster campaign this fall. So it's going to give some amount of a space for that conversation, but really it's going to require local trusted messengers on the ground to take those conversations and run with it. In pediatricians' offices, family providers' offices, really no wrong door in every space and setting, just reinvigorating that conversation, especially given the hope that some of the tenor of the politicization of the COVID vaccination conversation hopefully has dampened down just a bit for us to have a window to have that conversation. So that's one important thing for us to keep in mind. On the confidence front, yes, we have materials on wecandothis.hhs.gov. Yes, we've got spaces where we can share great information, but we've got to take advantage of the best messenger, and often that's local trusted messengers. On complacency, I think it's so important that we really reiterate to people that certainly COVID's not over. There's still a lot for us to do, but the reason we're not in the same space with this pandemic is because the resources and tools we have today are very different than what we had 2 years ago. And so, Mark with AAP just mentioned a lot of those resources, those mitigation efforts, but masking has to be a part of the conversation in communities, especially with our kids. If the notion is that they've gotten rid of masks henceforth now and forevermore, then it's going to be that much harder to then turn back and say, hey, our COVID community levels are rising. Now it's time for masks. We really have to frame it for our kids, much like when they need an umbrella for a rainy day, they need a mask when COVID community levels are high. Make sure that they're ready and they're prepared for that potential, especially as we head into the fall. And we're able to project what's going to happen with with COVID rates over the next 3 or 4 weeks with some level of accuracy. But really, as we get later into the winter, we know that the trend we tend to see with upper respiratory infections is that they increase as the year goes on. And I think if we're seeing any indications from the flu season in Australia, which tends to predict a little bit of what we're going to see here in the U.S. because they have their winter before we do, it's going to be a busy upper respiratory infection season. And so it's so important for us to remind kids about masks and the role that they play. Certainly tests, and I want to just remind folks, we had COVID tests back up. That was when we got a lot of tests to families, about 700 million tests out. We don't have that site available anymore because it ran out of funding. But people can, if they are insured, still get tests, 8 tests per month per covered individual sent to their home. We're talking about keeping kids safe, making sure testing is a part of the routine when there are those typical upper respiratory infection symptoms, really making sure that folks have tests in the home and are ready to take advantage of that. And certainly we're checking to see what's happening in stores in communities all over the country to make sure our supply is there. And we're trying to maintain the ability, if need be, to serve some tests to folks if that becomes a challenge later in the fall like it did last year. But again, taking advantage of the resources we currently have. We've talked a lot about vaccines so far today, and I think that's going to be such an important part, but just really wanting to reiterate, that's going to be huge for us as we move forward, keeping our kids as protected as possible. And then the last, which wasn't mentioned, is the treatments that we have. And certainly for kids over 12, we've got some oral antivirals that can be really helpful and prevent the worst of what COVID can do, particularly if they're at risk for severe disease. You put all those together, there's a lot that we can do to keep kids safe. I just want to say a word really quickly on the public education campaign. As I mentioned, we're really surging that up. So you'll see more communications coming from that We Can Do This campaign over the next couple of months. So we're excited about that. We're excited for the conversations. We hope that it'll reinvigorate in a lot of communities. But, above all else, we really need your help. We've heard, we have some focus groups ongoing right now, and the message that we're already hearing from parents and families and individuals is that they're tired, they're fatigued from the COVID conversation. They've seen the impact, they recognize how this moment is different, and they're trying to connect what they need to do in this different moment. But the really important thing that we need folks to do is have your highest level of protection. It is make sure that you are taking advantage of the resources and tools that we have. That's really our focus. That's how we're engaging with our local trusted messengers. That's how we're trying to keep people connected with what needs to be done on the ground. And we're trying to support as much as we can. Again, we wish we had more resources that we could send to community organizations like we did earlier in the pandemic. That was through great partnership with Congress. We were able to do that. We continue to work closely with Congress. We don't quite have the dollars coming our way despite our requests, but we're going to keep working to do everything that we can on that front. And the final word I'll say is we talk a lot about kids 5 to 11, but keep in mind, for kids under 5, a lot of those kids have siblings who are in school. Part of keeping kids healthy is taking a family vaccination approach. That means everybody. So with that, I'll turn it back over to you, Dr. Waddell. Thanks so much for having me join you all this afternoon.
Thank you so much, Dr. Webb, for reminding us and sharing those important C's, the convenience, the confidence, and the complacency, and the recommendations and thoughts around how to continue to address those, that we need to take a family approach. That's a really great reminder. And I love this. We need an umbrella and we need a mask. How do we keep these messages simple for our kids and our families? An umbrella and a mask. I'll remember that. So we do have a few questions and a couple minutes for questions. So I want to open it up. And I want to start with, I think probably Mr. Boyd, this one might go to you. But how can our CBOs partner with schools or local public health departments to increase vaccinations? And Dr. Del Monte, you may have some thoughts on that one as well. So we've got about 3 minutes, so 30 seconds. Go.
You can go start by going to our website, SBHforall.org, and look at our mapping tool. That will show you where the community health centers are in your community. That will also show you where the schools are that those community health centers serve. I would start with those two entities. The majority of school-based health centers in the country are sponsored and operated by federally qualified health centers. And I would start there with identifying what's the right match in my community. and approach the community health center, approach the school, and bring them together. That's what we're trying to do with that information on our website. Mark?
Yeah, thank you. Great answer. I think we should caution ourselves. There's not parents who are pro-vaccine and everyone who's anti-vaccine. There's people all over the spectrum. And I think the first thing that we've got to do is get vaccine to people who want it right now. We still have access problems for people who want their children to be vaccinated. And so we can't miss an opportunity anywhere, a school, a pediatric practice, a community setting, whatever that is, to get those vaccines into the arms for everybody who wants one. And then for people who have questions, let's answer them. Let's find ways, whether it's online supports or social media message campaigns or one-to-one conversations with clinicians or the school nurse or anyone else to get their questions answered in order to get people to be comfortable with vaccines. And then for the people who are really worried, we're going to have to give opportunities and make space to have those conversations and invite people into that. And I think there's enough of us who care about this and are working on this that we can make some progress in all those numbers that Dr. Smith showed us at the beginning.
Thank you for that, because that's been a common question that we've seen is for those that do still have questions and concerns, the parents, and you clearly have indicated that we just have to continue to answer the questions and be available. And I would encourage our listeners to be sure to look at the resources that have been added in the chats, because there have been community-based organizations that have partnered with different entities out there and have been successful in being creative in how they are reaching parents and others, including the use of arts, for example. So there's a question about, is it expected that the COVID-19 vaccine will be added to the Vaccine for Children's program? So, Dr. Meyer, do you have a crystal ball on that one?
Well, what I would say is stay tuned for next week's ACIP meeting that will be discussed about the COVID-19 vaccines appearing on the child, adolescent, and adult schedules, as well as discussion around use of the vaccine in the VFC program. So I would encourage people to tune in next week to the ACIP meeting.
Great. And I think with that, I'm going to do the quick round robin and go to you, Dr. Webb, first. If you've got 10 seconds, a final word of advice, support, encouragement to our community-based organizations, health departments, and other key partners on the line today, what would you share with them in terms of making sure that our kids are ready for school and get this vaccine?
Well, just a word of thanks. You've been incredible in this effort to this point, and we continue to want to lift up that work. And I've got 10 seconds here, so I'll just say we're pulling together a summit at the White House in the next few weeks where we'll lift up some of the promising practices that you all have put in place in communities to try to share those with more communities. So thank you, and we'll continue to try to lift those up.
That's great. I'm going to go to you, Dr. Smith.
I think just doubling down on what Mark was saying, plus one, go after and support the families who are interested now, and then create time and opportunities to have conversations for folks who have questions and need them answered before they move forward.
That's great. Dr. Meyer?
I would just echo the thanks to these organizations. I think, instilling vaccine confidence it starts at a very local level. If you can affect just one person with your conversation, that matters. It's not by, we can do everything at the national level to try to encourage this and support getting access to vaccines and encouraging vaccine demand, but it really takes individuals like you to make a difference, answer that parent's question, talk to that at that school organization. It's really thanks to your all's work that we're able to kind of move the needle and get more kids vaccinated and get our communities vaccinated. So thank you, and keep up the good work.
Thank you. We are at the top of the hour. We are going to go ahead and launch our evaluation survey. We want to thank you again, Dr. Del Monte, Mr. Boyd. I'm sorry we ran a few minutes short here. But again, just to highlight to everyone, you heard it here today, hot off the press. We need to get those bivalent boosters into the arms of our our children and our families. We've got compelling data regarding the importance of inequities. Much work still to be done. We've got to create a pipeline to make sure we've got the future generation of those that can help our children in schools. We need to follow those mitigation strategies that we know work, and we need to ensure that we are reaching the entire families. The time is now. Our kids are back at school. They're back together. Many of them are going to be going out and gathering during the upcoming holidays. And we want them all to receive as much protection as possible. And so we encourage all of you to continue your hard work to ensure that our children get their COVID vaccine, their flu vaccines, and all of the recommended childhood vaccines that we know are so important. Prevention is key. So again, thank you all for all of your work. And thank you to all of our speakers for sharing your expertise today. Until next time, stay safe.